Welcome, Stephanie and Uriel.
Hi, doctor. Good night.
Hello, doctor.
Okay, I'm gonna be doing some stuff, so just you can even greet people. Well, you don't have to greet people when they come in. I guess just wait. Just wait.
Doctor?
Or yeah, or let me make you administrator. You know, Uriel, I don't think you're admitting the people yet. Let me show you what you need to do. Let me make you
Okay.
make you. Yeah, it's great having help, especially at the beginning of the webcast. Okay, now you're both co-hosts. Now, what you got to do, Uriel and Stephanie, you go over the name and it says more. You click on the more and it asks you to promote to panel. That's you want to go over there every now and then and do that. Because some people will sit there for like a half hour without getting promoted.
Okay.
You know what I mean?
Yes, promoting to panelist.
Yeah, just go over
Okay.
more and admit to promote to panel. So
Got it, doc.
yeah, I'll be back. Hey, Byron,
John, buenas noches.
you
Hi,
want to
how are
go
you?
over that video?
Yeah, please,
Doctor
let
Byron,
me...
muy buenas noches.
Uriel, buenas noches. Sí, John, más o menos si me indica cómo
Okay.
poner
Okay,
los settings.
abre la video en su desktop.
Ya, bueno, el vídeo se está cargando ahora.
Okay. Oh, está
Está
hard
bajando.
drive, huh? No, está en,
It's downloading right now. Yeah.
okay.
So how do I do it when it's already
Desde comparte,
downloaded?
abre la video y comparte la pantalla de video. Es lo mismo como pila.
Okay.
Okay.
Let me see if it's right.
Y cuando va a abrirlo, se pregunta, quiere poner sonido y al fondo. Yo voy a mostrar, ok. Mira mi okay, déjame ver si yo puedo hacer. Espera. Ok, cuando yo, ok, Byron, ¿está allá, Byron?
Aquí estoy, John. Sí.
Ok, yo empiezo a compartir pantalla, ok, cuando yo abro esta ventana, hay una opción al fondo, dice que compartir sonido, necesita marcarlo y después va a compartir cualquier cosa que quieras. ¿Quieres probarlo?
A ver, entonces pongo share screen, ¿no?
Sí.
Pero tengo que abrir primero un video, ¿no?
Lo ponga en la desktop video para accesar.
A ver,
Para,
a ver. Solo un minuto. Estoy buscando un video que tenga video, sonido.
¿Está en internet, YouTube o solamente en fila?
Un file.
Oh, ok. Buenas
Pues
noches, Flo.
ya tengo ahí. Entonces, bueno, perfecto. Entonces, ¿qué abro? Share screen, ¿verdad?
Sí.
Ya.
Ok.
Pongo desktop.
Espera. Sí. Ok. Y compartir el video. Ok. Toca play.
Ya.
No
Did it
puedes
sound, right?
yo creo que no ha ponido opción de sonido. Toca, ábrelo. No puedo oír nada.
¿Se escucha?
No puedo oír nada.
No, doctor, todavía no.
Ok,
No se
no
escucha.
ponga la opción de sonido.
¿Y dónde pongo la opción de sonido?
Ok, cuando
A ver,
abra
doctor.
compartir pantalla.
Deje de compartir, a ver. Ya.
Cuando deje
En
compartir pantalla.
el botón de compartir pantalla, cuando usted va
Pone
al
share
lado de la
sound.
flechita.
Yeah,
Ajá,
SOS.
exactamente.
Vamos de nuevo ahí.
Toca el video.
A ver, un ratito. No está. ¿Qué pasó? A ver, ¿qué dicen? Dice que tengo que reinstalar
No, eso es, ok. Entonces abro el video, compartir la pantalla, abro el video, o cualquier quiera hacer primero. Si empieza a compartir, pero no siga, no sé.
Sí, dice, please restart your audio sharing application after installed computer sharing computer sound.
¿Puede compartir que dice, o muestra que dice ese mensaje?
Dice, to share your computer audio, please install the Zoom audio device. Please restart your audio sharing application, such as the media player, after installed to continue sharing your computer sound.
Ok, ¿puede hacerlo rápido?
Eso estoy intentando.
Necesita reinstalar Zoom, ¿verdad?
Sí, porque no me dejan.
No puede, tú puedes salir Zoom y regresa. Necesita bajar Zoom lo más nuevo, ¿verdad?
A ver.
O puede mandar la fila a mí o Uriel o alguien.
Yes, doctor. Sí, doctor. Puede enviarnos los videos para que nosotros lo
Manda el video a
buscamos.
Uriel, ¿ok, Byron?
A ver. Uriel, mándame tu dirección de email ahorita.
Listo. A su WhatsApp se lo envío.
Manda por el chat por aquí para copiarle. Y te mando este momento.
Listo, doctor.
Doctor Bennett, doctor Byron, buenas noches.
Buenas noches.
Listo, doctor.
Ay, bueno, ok. Vamos a probarlo, Uriel. Ok, es una presentación de la persona que no va a venir. Va a poner su video.
Sí, él va a estar al último.
Buenas noches, Félix.
Buenas noches, ¿cómo está? ¿Todo bien? Buenas
Bien,
noches.
muy
a
bien.
todos.
Buenas
bien.
noches, John. Buenas
Buenas
noches,
noches.
doctor Félix.
Sí.
Gusto de saludarle.
Buenas, Jorge.
Profesor Pérez, buenas noches.
Buenas noches, muchas gracias por la invitación.
Buenas noches,
Muchas
qué
gracias.
gusto.
Mucho gusto.
Doctor Jorge, buenas noches. Doctor Pérez, buenas noches.
Uriel.
Buenas
Qué gusto
noches.
verles.
Un gusto tenerlos aquí.
Muchas gracias, muchas gracias.
We're going to do something new tonight. Nosotros vamos a hacer algo nuevo esta noche. Yo voy a explicar cuando empezamos, o antes de empezar, cuando todo está aquí. Si yo puedo explicar el fin de la charla. Ok, entonces,
Uriel, ya te acabé de mandar, por si acaso, si puedes chequear en tu email la
Sí, doctor,
dirección
ahorita justo ya lo tengo. Listo.
para bajar.
ok.
Professor Yoko Kato, welcome.
Hi, good morning, but good
Hi.
evening for all of you.
How are you?
Hi, how are you? Thank you
Thank you
very much for
joining
inviting
us.
John,
Welcome.
how are
Hi,
you?
Professor
Welcome,
Kato. Nice
Dr.
to see you.
Hi. So
Welcome.
now, hi. now the Professor Goto is with us, and Dr. Watanabe is coming soon.
Professor Goto, nice to meet you. Thank you for being here.
So you know him or each other already.
Let me explain something. We're going to try, Dr. Cato and Jorge and Fedis. After the webcast, we're going to try a quick Zoom, a private Zoom, so the students can meet you, Dr. Cato and Jorge and Fedis. It's going to be private, not televised, to try to improve the networking, so the kids get to meet you. So can we do that after? It's like 5 minutes. Okay, Takashi, how you doing? Welcome.
Welcome, Professor. Takeo
Hi,
Goto.
Dr. Kato. How are
Professor
you?
How are
Kato,
you?
Yoko,
Fine.
welcome.
Yeah,
You?
nice to see you.
Nice to see you. See.
So So we work together in Vietnam.
Yeah,
Yeah.
thank you for would
Yeah,
like
it
to
was a
thank
few
you
years
for
back. So
for
Maybe,
having writing the foreword of my book. Thank you so much. Thank you.
thank you very much. Thank you.
Thank you very much.
And Dr. George, once again, thank you very much for your contribution. Thank you.
It's a pleasure. We're very happy to have you here, all of you distinguished professors.
Thank you. Thank you for invitation for all of us this time. Professor Goto, hi. Good morning. How are you?
Hi, good morning. How are you?
Hi. Hi. But Professor Watanabe, good morning. How are you?
Hi, good morning and good evening,
morning.
everybody.
Yes. Yeah, good evening.
Thank you for the
Professor Watanabe.
Dr.
Good evening.
Takashi
Thank you
is
very much for being
translating.
here with us.
Welcome, Professor Watanabe.
Good morning.
Good morning.
Yeah,
Good
Dr.
morning.
Takashi is translating Dr. Cato into Japanese.
Yes, for Japanese participants, I will help to translate English to Japanese.
Thank you very much, Takashi.
Thank you.
Profesor Gadea, buenas noches.
日本語に訳していただくんですか？
私、日本の、参加者とか、周りの方で、同時通訳の、協力させていただきますので。
大変な仕事ですね。
非常に勉強になりますので。
Tudo bem?
Tudo bem, meu amigo?
Tudo bom?
Okay, Flor, you ready?
Listo,
Profesor
doctor.
Gómez
¿Quiere que
Amador,
lo
muchas gracias
presente?
por estar aquí. Doctor Caballero, profesor.
Buenas noches, un saludo para
Muchas
todos.
gracias por estar aquí con nosotros.
Gracias.
Welcome. Are you ready, Byron?
Yeah, I'm ready.
Oh, okay, Flor, 10, 9, 8, 7, 6, 5,
Doctor, ¿quiere que lo presente en español o en inglés?
No en inglés, claro. Ahorita comenzamos todo en inglés.
Okay.
En inglés lo presento.
Okay. 10, 9, in English. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1.
Good evening to all people who follow these neurosurgical TV platforms. My name is Flor de María Ibáñez Loaiza, and I am a member of the Neurosurgical TV student team. For me, it's an honor to present one more Friday the continuing medical education course of the Ecuadorian Society Neurosurgical by Dr. Byron Salazar.
Thank you very much, Flor. We are very enthusiastic to welcome you all to our continuous medical education courses in neurosurgery. These series are organized by our scientific program, scientific committee of the Ecuadorian Society of Neurosurgery, and our sponsored by the International University of Ecuador and the Metropolitan Hospital. I would like to thank Dr. John Bennett, Neurosurgical TV, the Peruvian Student Neurological Society, SOPEN, and our explaining group of speakers, panelists, and special guests that are here with us tonight. We have the honor to have today Professor Yoko Kato, President of the CNS, one of the largest and most important neurological societies of the world. And these webinars aim to offer you a wide range of surgical techniques and knowledge, and which will be skillfully presented by experts from different fields. So we also look forward to engaging with you in the discussion and hearing your valued opinions and thoughts after each conference. So to begin, I want to introduce Professor Jorge Salazar, Neurosurgeon Chief of the Metropolitan Hospital, to give our presentation of our keynote speakers.
Good morning. Welcome to all of you for this international webinar. Thank you for your collaboration with the Ecuadorian Society of Neurosurgery. We are very pleased to have our international speakers. And in the first place, I would like to introduce Professor Yoko Kato, MD, PhD, who is actually the president of the Congress of the Asian Congress of Neurological Surgeons. She is professor and chair department Neurosurgery, Fujita Health University Vantana Hospital, head of Fujita Stroke Center, executive board member of the Wealth Federation Foundation, chair Wealth Federation Foundation International Initiative Coordinating Committee. She has been editor of several international neurosurgical magazines. She is executive board member of the Japanese Neurological Society. She has been secretary of the World Federation of Neurosurgery, member of the editorial board of several journals, advisory panel board of World Neurosurgery, and she has been given the World Federation of Neurosurgery Medal of Honor, and she is also honorary fellowship award, American College of Surgeons, and International Lifetime Recognition Award. So we have a very, very expert neurosurgeon who has developed educational teaching and neurosurgery around the world. So we are very happy to give you our best welcome. Professor Yoko Kato, it's all yours.
Thank you very much, Professor George, and all the Ecuador Neurosurgical Society, especially Professor Byron. The last time I met Dr. Byron, he was invited to our committee, the webinar. So I recognize his high ability, and also I recognize him a very nice the neurosurgeon. Then I discussed with him that we finally decided to have so many invited guests today. Thank you very much, because those invited guests are very much proud of the Japanese Neurosurgical Society, and also I'm very much proud of them. So at the beginning, just I want to share with you my presentation. Thank you very much for a kind invitation this time. So I visited Latin America several times, but I never been to Ecuador. So it's very exciting to meet in virtual. But today, my short topic is the role of the recent aneurysm surgery, maybe with era of the endovascular treatment. So role of the surgical clipping for several aneurysms.
Professor, we are not seeing your screen.
Really?
No, we are not watching it.
Okay, so just wait.
I'm sorry, I missed that.
Can you see my screen now?
Yes.
Yes, Professor.
Okay, thank you so much. Sorry for my mistake. So today maybe I will just discuss with you what is the recent role of the aneurysm, the open surgery. So this is just the short summary. The space occupying the intracranial hemorrhage more than 50 millimeter. This is class 2 level B, and MCA and pericallosal aneurysm location, class 3 level B, and blister type aneurysm or unfavorable anatomical neck for coiling, the class 3 level B, and failed endovascular treatments, the wide neck aneurysm, class 3 level B, and retreatment after coiled aneurysm, the incomplete obstruction, the subsequent, the growth of the residual neck or dome, increase of the coil mass effect, young age, and a good clinical grading. So this is for the younger generation. The recently in Japan, most of the young generation of the neurosurgeon can have a both board certified. So in Japan, we need to the endovascular board for treat of the endovascular treatment. So anyway, there's so many the knowledge and the skill they need if they deal with either the open surgery or endovascular surgery. So this is very, very important. So that is your choice, your decision. That is very important for YNS. So the so-called hybrid approach. So that means is if they want to do the open surgery, that they need some skill of the bypass surgery. So this is our department routine, how we can put the final clip. Hemodynamic blood flow, such as intraoperative ICG or DVAR or endoscopic ICG with Stolz company, and also, of course, the physiological function, and also aneurysm wall property. We can estimate the thickness of the wall with the CFD. So this is just how we can use the endoscope. This is a SCA and MCA aneurysm. So before start of the surgery, all the case we check the CFD. Then we can estimate the which part is very thin or thick. So this is a MCA aneurysm through the dissection of the cerebral fissure, and this is the deeper part was a vaginal tip aneurysm. So some part is very thin. And this is with observation and endoscope. We can see so many anatomy, vaginal and PCA and the perforators, everything we can see under the endoscope. So this is an endoscopic observation of the MC aneurysm. 360 that we can check with the endoscope before surgery. So this is just how we place the clip. And so after placing the clip, then we can once again watch about the situation of the clipping, the condition, and where is the remnant part of the aneurysm. So many small perforators we can recognize with endoscope very clearly. So this is a fenestrated clip. Will close of the remnant part of the vaginal tip aneurysm. Sorry, the SC aneurysm. So back to the MC aneurysm, because MC aneurysm is a good indication for open surgery. Everybody knows because of the neck. Is most of the MC aneurysm is over the 2/3 of the MC trunk. So sometimes very complicated clipping way. So this is one of the endoscopic observation. So what about the giant aneurysm with the partial thrombosis? Is it good for endovascular or open surgery or bypass? So this is a treatment option is, of course, giant aneurysm is with trapping the with bypass. And of course, flow or dilator endovascular treatment will be offered recently. So you can see so many the edema or very layer by layer of the inside of the aneurysm. That means is some mechanism of the growing of the aneurysm is totally different from the usual the ballooning of the aneurysm. So this is some cause of the partial giant aneurysm, how it becomes the bigger. So extrinsic factors and mural hematoma and the intrinsic factors. And those things is some dissection of the wall and with hemorrhage, repeated hemorrhage, and the recurrent dissection and partial thrombus. Very multi mechanism. So this is one of the case of the brainstem compressed with VA, the giant aneurysm, the partial thrombus. The patient went to the neurosurgical institutes. They repeated the stent coil, again a stent coil. You can see that this aneurysm wall is well defined, maybe due to the filling up by basal. So we can see this small, the faint contour of the aneurysm. This is a stent coil. Also, we can recognize with this. So patient started 2013, and finally they came to us. Many times, many technical endovascular treatment does not work. So this is just I want to share. So after release of the CSF, so now we can see there's so many basal on the wall. The aneurysm wall became very thick, and with so many basal on the aneurysm wall through the lower cranial nerves. Then for this case, we excise of the aneurysm wall and the removal of the clot and also the coil. So this is this is endoscopic the viewing, and so many coils inside. We can see, and the clot we removed finally. Then trap, and again this is a stent which was put at the previous hospital. So this is one of the way we can treat. So this is a histopathology. So vasovasorum, the small network of the blood vessel which supplies the walls of the large vessels. So this is one of the cause of the enlargement of the aneurysm. So vasovasorum is just the kind of the nutrition of the external membranes. Here you can see the structure and tunica adventitia. And this is another case, is a large cavernous sinus, the giant and the large type of the aneurysm in both sides. The patient is a 24 medical student, and just as she started with a headache. So of course, recently the flow diverter, several flow diverter can solve this the big lesions, but we can do the high flow bypass with sacrifice of the main trunk. So STMCA insurance bypass at the beginning, then followed by we place the high flow bypass in between the M2 and the external carotid artery. So step by step. So in the good perfusion, we confirmed with IgG. So this part is looks pathological. So we excise and send it to the pathologist, and the diagnosis was Ehlers-Danlos syndrome. So the indication for high flow bypass, so everybody knows. So this is a failed balloon test occlusion and inadequate CBM. Of course, giant aneurysm, the cavernous portion, and the very broad neck, fusiform aneurysm, or severe atherosclerosis or a calcification in the neck area, or extensive the thrombosis aneurysm. The origin of the critical branches from the aneurysmal sac or neck, or symptomatic dissecting aneurysm and small vista aneurysm. So this is one more case. This is MCA. It looks like the usual MCA aneurysm, but the patient came to us with infarction. So we thought some thrombus inside of the aneurysm. So then we decided to put the bypass, and we opened then we decided some other surgical techniques. So this is a schematic drawing. This is the aneurysm itself. Some part is very yellow, very sick part, but some part is some thrombus inside, I think. So this is the preoperative Amira 3D images. So then we did the bypass surgery to M4. Then we excise one branch of the here. Then we reconstruct the MCA, the aneurysm. So this is one of the way we need the direct surgery. So it is completely occlusion of the aneurysm. So this is one more another case. This is left the VA, the large type of the aneurysm. So unfortunately, the pica is come from the aneurysm dome itself. So we did the OA pica bypass. Then we drop of the aneurysm. So the ICG or bypass technique, or so many skills is required to complete solution of the aneurysm. So this is so we put the bypass surgery, and then we chop of the aneurysm neck. So this is the before clipping. This is after clipping the flow 800. So normal flow in the aneurysm. But this is a bypass is. So this is maybe last case. I think this is H3 aneurysm. So this is actual surgery. So before surgery, we can estimate. So this part is very thin, and this part is very thick. So this is just. So again, this is a CFD that tells us which part is a very thick and the thin. So, but I think I will tell you. So this is the aneurysm itself. So this part is very thin, and this part is very thick. So this type of the peripheral SCA aneurysm cannot be treated by endovascular. So this is one of the option for open surgery. So this is a flow line. So this is endoscopic, the viewing. So this is a very thick part. So at the beginning, this part could be very thin, but later on it became very thick now. Then it moved to the thin part, is come to the another place. So this is so one of the options for open surgery. So this is a white plate and this is a red plate. So this is a white plate is increasing of the fibrous layer, and the red plate, the very thin part, is limited elastic layers. So one more last. So recently we introduced this Amira preoperative imaging. So this is just a bypass case. So the bypass case is just before the surgery, which recipient will be decided. So this is a STA, so just usual manner. Then we can estimate. So these vessels, this is a recipient vessels that we can estimate before surgery. So that is one of the good preoperative 3D images, I think, in the future. So just, this is, and this is one last case is MCA in Fear Parasite. So again, and this is so this is a Fear Parasite of the MCA aneurysm. So now we can see the whole aneurysm shape and the location. So this is a CFD, just we can compare the which part is a thin or a thick, and this is the streamline. And also this is a very operative, we can estimate the involving of the gyrus. So exactly the same, the figures we can get the before surgery, then we can put the clip. So this way is just usual manner, and also we can check. So this aneurysm, the complete obliteration of the aneurysm neck confirmation with endoscope. So this is once again this is the role of the surgical clipping at the area of endovascular. So I think for young generation, still you need some technique, the bypass or deep consideration how we can treat those type of the aneurysm. The future trend of the neurosurgery is, of course, the robotic assisted micro or stereotactic surgery, and also the AI in neurosurgery. It's getting popular now. The virtual reality or detailed 3D visualization for extremely small robotic instruments, the image-guided surgery or functional MRI, nuclear medicine imaging, and the gene therapy, stem cell, and the tissue transplants, and also telemedicine. And even though the ICG or video angiography or fluorescent or so many new devices, and also the bypass skill, it's very, very important. Thank you for your attention. Hopefully, Linus can understand my very rapid talk. Thank you very much.
Thank you very much, Professor Kato. I think we are all so happy to have you here. I see why you are one of the best surgeons in the world, an excellent technique, amazing images. So I think we all learn a lot. We are going to start a little bit of discussion each lecture. And we have with us Professor Feres Chadat. I guess he doesn't have, we all know him, no? He doesn't need any introduction, one of the best vascular surgeons in the world and neurosurgeon chief of the USP in Brazil. So I would like Professor Chadat to share us a little bit of your experience of what Professor Kato has just said. Any comment you want to do?
Thank you, Dr. Salazar and Dr. Jorge for the invitation. It's a pleasure for me to be here. Professor Kato class was very interesting and the cases are very complex. I am very honored to be here with you today, Dr. Kato, and I am very grateful again because Dr. Kato, she has writing the foreword of my book, okay? My book will be released next year, I think in 1 or 3 months. Nowadays, the microsurgery is still gold standard for the aneurysm treatment. Efficiency and safety of microsurgeries is based on new technologies, 3D microscopes, 3D microscope, intraoperative angiography with indocyanine, hybrid room, intraoperative electroneurophysiology, studying neurological anesthesia, neurological intensive care unit, and the lab study. I have a lab with 21 stations. We've had cavernous sinus, temporal bone, and I believe that the microsurgery is the best treatment for the aneurysm. Thank you, Dr. Byron. Thank you, Dr. Cato. Dr. Cato, again, it's a very honor for me to participate with you. Okay? Thank you so much. Thank you, Byron.
Thank you very much. Thank you, Paris.
Dr. Cato, your lecture has been approved of your excellency in neurovascular surgery. And this time, when the endovascular procedures are gaining land over the surgical treatment, what would be your advice to young neurosurgeons? Are we going to be out of business, or what do we need to do to keep doing our surgery? What's your advice? What we need to learn? What young neurosurgeons need to do? Please.
Yeah, thank you very much for your very good question. But I'm just worrying about, because the younger generation, the teacher is their education is just endovascular era. So I think the teacher should have more skills for open surgery. Otherwise, they cannot teach the younger generation. But besides that, I think the younger generation need to such a practice bypass or some other clipping techniques, or the concept how we can treat the aneurysm way. So I think they should learn with video, or you should go somewhere as a fellowship, or 1 week, such kind of the Dr. Paris demonstrated a nice caliber, maybe the course. I think time to time they can find their time to keep the learning, learning to the not only the skill and also the knowledge. That is my opinion. Thank you very much.
Thank you, Professor Cato.
Thank you.
Professor Cato, we have here Professor Juan Luis Gomez Amador. He's the director and professor of the school-based and endoscopic neurosurgery program in Mexico. He would like to make some comments. Please, Professor, go ahead.
Thank you, Byron. Good night to everyone. Good morning to all of you in Japan. I'm very grateful to Professor Yoko Kato for her excellent presentation. I think she made aware to all of us that the knowledge of the literature before treating a patient, and also having a very careful analysis of preparative image is the best help that we can get to treat an aneurysm. So I like a lot when you show the MCA aneurysm in this orthogonal clipping technique, the benefits of using the endoscopy in a case that we should think that it's too superficial to use endoscopy, right? So this demonstrates to us that endoscopy definitively provides the surgeon with a different view, so you can organize your mind in order to have an adequate clipping of aneurysm. Another fact that is very important during these days of endovascular therapy is the fact that neurosurgery definitively has a major role for the compression of giant thrombosed aneurysms previously treated by endovascular therapy. Sometimes using the conventional corridors, trigeminal, suboccipital, etc., but also it can be done through the endoscopic endonasal approach for some very specific cases located in the basilar trunk. Also, the importance of using the bypass techniques for some complex cases. And I would like to ask Professor Cato, what do you think about the Yashar-Gill technique, the stepwise technique using bipolar coagulation to configure properly the aneurysm neck? I think this technique in some cases is very helpful in order to avoid a bypass for some cases. And thank you very
much.
much. Excellent
Thank
lecture.
you. Excellent comments. Thank you so much. So I know that he's very good techniques, but I'm not so brave to coagulate the aneurysm. If the aneurysm wall is a very thick part, then we can, how they say, make a very nice shape to for easy to put a clip. But I think a very thin part is very dangerous, I think. So always, if you want to coagulate, just you can be prepared whenever it will be ruptured. So then it's okay. But I think that is one of the good way to put the nice clip. Thank you very much. And also one more thing is the endoscope. The endoscope is very nice, but still the diameter is very large. So when we apply it to the posterior fossa, it's so many cranial nerves and also vessels avoid to insert with such a large caliber of the endoscope. Maybe in the future, then we need a more smaller one, I think. Thank you very much.
Thank you, Professor Kato. Very assertive comments. I would like to give the word to Professor Luis Felipe Alencastro for his comments. Please, Professor.
Nice to meet you again, Dr. Kato. It's a pleasure. Many long years later.
Yes.
Yes. Maybe one time next time in Japan again, in Nagoya.
Yes.
Dr. Kato, I have a question about endoscopy, and I think that Dr. Ferris has make a good point that we are also in a good rate of evolution in neurosurgery, in vascular surgery, in microsurgery, because many times we just listen about the evolution of endovascular surgery, and I think we have many enhancements in microsurgical development. So this is one point. But my question is about endoscopy. We have been using also endoscopy in many cases for checking pre-clipping and post-clipping. And I've seen many studies talking about for example, for school-based meningiomas in the anterior base, using microsurgery and then endoscopy in the end to see if you have residual tumor, and you have publications that you can change the result of surgery as much as 40%. My question is, if you have data on microvascular or on aneurysm surgery about how many cases you made an endoscopy after clipping and you saw something that made you change the position of the clip. That's my because I've never seen something written about that in the literature.
Thank you so much. So my case is not so many, but just we are concerning about the perforators. The perforators, it looks very well avoid to the clip, but sometimes monitoring tell us it's very dangerous patient. So I think it's about 5% replace again with the endoscope. So not so many like literature, I think.
All right, thank you.
Thank you very much. So we work together maybe in the future.
Yeah.
About the tumor, maybe the later.
Thank you, Professor.
Yes. Thank you very much.
Thank you, Professor Kato. Maybe one final question. We all have heard about proximal control, and when we think about neurosurgical techniques, it's a little bit, let's say, more easy to know where our proximal control will be. When you are approaching an aneurysm only by endoscope, what would be your road to think where is going to be your proximal control, because of the difficulties working with that? How you plan the surgery about the proximal control when using only endoscope?
So before starting the surgery, we prepare such as a suction decompression or proximal control at the neck. So we always prepare the where we can put the temporary clip or such kind of idea, I think. So I think only endoscope. Only the endoscopic.
I'm sorry, keep going.
Yeah, confirmation is difficult, I think. So always you should control of the placing the clip or suction decompression or either or endovascular or direct surgery. Thank you.
Thank you.
Professor Amata Awad would like to make some comments. Please go ahead.
Hello. Ohayo gozaimasu.
Hi,
Good evening. Good evening and good morning to everyone. Thank you very much. Thank you, Professor Bennett, Professor Salazar, and Professor Kato for supporting Afghanistan neurosurgery. And I agree with you that you always supporting Afghanistan neurosurgery, especially women in neurosurgery. And we agree with you about the scale and knowledge for especially for young neurosurgeon. Unfortunately, you know, in Afghanistan, just we evacuate the hematome from ruptured aneurysm, and we haven't possibilities for doing such advanced techniques and surgery. And we like your attention and all our colleagues all over the world about for supporting for Afghanistan to gain advanced technique and skills for neurosurgery. Arigato gozaimasu. Gracias. Thank you.
Thank you. Thank you very much. I think you should learn in future, maybe the endovascular. We can teach young neurosurgeon.
Okay.
In Afghan.
I would like to ask, yes. I would like to ask Professor Kato, what do you think about the hybrid neurosurgeon, the one who performs surgery and also endovascular procedures? Do you think this is a current technique, trends around the world? Should we be training new neurosurgeons to do both things at the same time? And I also would like to have, after your comments, the comments from Professor Chedat to see what's the difference between Latin America and Asia respect to this. Please, Professor Koto.
Okay, thanks so much. Because in Japan, we have an endovascular society in Japan under the umbrella of the Neuropsychiatric Society. And more than 6,000, I think, endovascular board doctors. So they can decide by themselves how they can treat. Maybe such as Dr. Pizat, he said, once we evacuate the clot of the MCA ruptured one, then we place the coil by one doctor, or at night, they can decide by themselves. Maybe whole China, young doctors, and also Japan, almost the same tendency. They can do both, so-called hybrid neurosurgeon. I think they will have a lot of advantage with confidence. Thank you very much.
Very interesting, Professor Kato. The same question to Professor Ferres Chedat, please.
The decision in Brazil is the best, the doctor of the patient, the doctor of the patient. In my hospital, the decision is mine. Okay, if I can condition to treatment the aneurysm in open surgery, I operate this patient. Okay, if the patient doesn't have condition to be operated, I use the endovascular procedure. But most of the cases for me, I use the open surgery.
Thank you, Professor. Dr. Zurita from Ecuador had a question. Has raised his hand? Dr. Zurita?
Yeah, I don't have the image from the conference right now, I don't know. But I want to thank Professor Kato for impressive speech. I want to ask some questions about the technique for clipping posterior fossa aneurysms. My question is there any role of the epidural, intra-dural approach, that is the Dolenz approach for vascular tip aneurysms, or you prefer maybe the pretemporal intra-dural approach? What do you think about it, Professor?
That is maybe view of the Dr. Professor Ferris, but I think the recent my case, just the bulging of the aneurysm in the bone anterior process. So I think it's quite difficult to the exact location of the paraclinoid aneurysm, intradural or exodural. You cannot estimate just the location of the ophthalmic artery. So sometimes ophthalmic artery is from the exodural. So I think you should have, of course, a knowledge and a skill how we can drill anterior process very precisely. That's very important. So the young generation should learn how to drill. Thank you very much.
Thank you, Professor Yuko. It has been a wonderful lecture and very interesting comments. We would like to advance with our next lecture. Thank you. Professor Tadashi Watanabe, who is Associate Professor, Department of Neurosurgery, IT Medical University, who is going to talk about minimally invasive endoscopic and exoscope keyhole approach. Please, Professor Watanabe.
Okay.
Welcome.
Thank you, Professor Salazar, and thank you for giving me an opportunity to make a presentation here. I'm very honored to be here. And today's my topics is minimally invasive endoscopic and exoscopic neurosurgery. So let me start my lecture with my recorded voice. I am working on minimally invasive endoscopic neurosurgery for about 20. I started this endoscopic keyhole approach since 2007. So initially,
we lost the audio, Dr. Watanabe.
Simple cases like this, but by development of the tools, gradually we are doing complicated cases recently. Yeah. So in 2019, when I moved to IT Medical University, we have got 3D VTOM by Stolz. So we started to use Exoscope with this approach. So since then, we are doing almost all the scheduled cases of brain tumor cases with this exoscopic and endoscopic approach. So we can switch the viewpoint of outside and inside the surgical field to obtain appropriate view. And surgeon and the scopist proceed the surgery together. This will be a 3D VTOM. We wear the 3D glasses, and this is the hand controller. We can adjust the focus and zoom with this switch. So what is the advantages of Exoscope? First of all, it is small. Like this, it is smaller, much smaller than a microscope. So it means good handling. And we can switch to macrosurgery easily. And this is a microscope. It is much smaller than microscope. And the second of all, it has a free visual access. Like this, we can see the objective with a horizontal visual access. Even we can do a lookup surgery also. So it provides us a comfortable posture of surgeons and the patients. Yes, compared to a microscope. And the scopist control and adjust the position and focus and zoom, so surgeon can concentrate on the surgical procedure. And all the staff can share the same field of view as the surgeon. So it is very good for education also. And it is cheaper than my microscope. Actually, these advantages are almost same as the endoscopes. And the most important one is it is exchangeable to an endoscope as appropriate, because it is the same heads-up surgery. So by looking at the monitor, we can seamlessly change to endoscopic surgery. So about the disadvantage, in this system, it is still insufficient images with high magnification. And actually, the visual axis and the optical axis are slightly different. So when we look at the deep side from a small craniotomy, some small problem will happen. And sometimes it is the white out happen with the white tissues or drilling of the bone. So adjustment of exposure is a little bit complicated. But the scopist will adjust the exposure or and change the position. And also, of course, the endoscope will resolve the image problem. What about endoscopic keyhole surgery? The advantages are from a small entrance and we can look at the wide viewing angle, and underwater surgery, we call it wet field technique, is available. And the drawbacks are there is confliction of tools with the endoscope itself. And sometimes the shallow part of the surgical field can be a blind area. So we use curved or flexible tools to avoid a confliction. And also a scopist will control the position to avoid the confliction. And sometimes the exoscope will resolve the shallow part manipulation. The scopist provides a precise adjustment of the endoscope to maintain a good field of view and to avoid a clash of instruments. And the scopist move the endoscope along with the instruments to prevent tissue damage. And always put the finger on the shaft to make a meticulous movement of the endoscope. These are the curved or flexural tools. And this is the setup of our operation theater. And this is the hand controller. And this is the scope stand. We can put another scope here. And this is Union is a floor standing pneumatic holder. So, so I'm going to show you the video of a case of CP angle epidermoid cyst with the trigeminal neuralgia. So now craniotomy is done with a surgeon with a small skin incision and about 2.5 centimeter craniotomy. So everyone can see what the surgeon do on the monitor. So 2.3 craniotomy is done. And from the dural setting, the surgeon is looking at the monitor. And the scopist is controlling the position and the zoom and focus. So now we are drainage the CSF. So the scopist is moving slightly for a surgeon and adjusting the focus. So when the whiteout happened, we can control the exposure like this AEL button. We can control the exposure. So now we can look at the white tissues, nerves and epidermal cyst. And clearly we can see. So in this approach, the patient is placed in a supine lateral position and the head is rotated 19 degrees. So it is easy to set up the patient position. So as you see, you can do a microsurgery without any problem with a 3D exoscope. So we can control these tiny vessels on the tumor. We are dissecting around the petrosal vein with the exoscope. So now below the seventh, eighth now, there's a tiny vessels, the tumor. As you see, the assistant can serve the body, because there's much space here about the surgical field. So now we change to the endoscope. So quickly we can change to the endoscope. So the scopist will control the endoscope from with the surgeon. Put the finger with the shaft of the endoscope. So endoscope and the tools are going into the surgical field together. So now you can see the much wider viewing angle compared to the exoscope. So now you can see that this tiny vessel is feeding the brain stem. So we have to preserve these small vessels. So we are now dissecting these small vessels from the tumor. So this part, ventral side of brainstem, is difficult to observe by exoscope, but easily to observe by endoscope. This is the last part of the tumor dissection. Then we can removing the membrane from the field now in a wet field technique. So mostly the tumor is resected. So the tooth and the endoscope is moving together like this. So we can get as safety. And now we are changed to the angle scope, the 30-degree scope, to look into the internal meatal canal because the tumor is a little bit embedded into the canal. So we confirm the tumor is left inside the meatal canal, underwater field. So all the tumor is gone. So we change to the exoscope again and we close the wound. Okay. Okay, I show you another examples. This is the middle fossa meningioma. In this case, when we do a microsurgery, we always remove the zygomatic arch to make a craniotomy just on the tumor. But in this case, by using an endoscope, we can remove the tumor like this. So we don't need the zygoma cutting. So we could remove the tumor with a small craniotomy. And this is the metastatic tumor here, just beside falx. So the best way to approach this tumor is from medial, from a falx side. So in this case, by setting the patient head like this, maybe 80-degree rotated, with a small craniotomy, the gravity will make the brain sinking down. So we can make the space between falx and the brain. So by endoscope, we can easily observe the middle side of brain. So we could remove the tumor. Also, this is the parasagittal meningioma. Just above the tumor, there is a diploic vein and also the bridging vein also. So we approach it, this tumor from frontal side. So this size of craniotomy at the midline is made, and we are observing from frontal. We dissect this tumor from the brain. There was a tough, there's a tough attachment, so we change to endoscope. So we are detaching the tumor from the falx and sagittal sinus, and we can remove the tumor from frontal. The craniotomy is here, so we are looking at the tumor like this. This is C1 meningioma of 86 patient with a minimum 1 or just a hemilaminectomy of C1. We could remove the tumor with the exoscope and endoscope without retracting the brainstem. This is a case of petroclival meningioma with its extending above, compressing the pons and midbrain. up to ambient system, and also it is extending into the Mako cave. So with the lateral suboccipital approach, we did the surgery. By using an exoscope, we decompressed the tumor, and by using an endoscope with a wide viewing angle, the detachment and the dissection from the brainstem, and leaving the nerves, third nerve, and this is the PC, and the fourth nerve, that we left every cranial nerves, and all the structure is confirmed, and we left a small part of the tumor at the Mako cave. Otherwise, we removed all the tumor, and then the compression is relieved. And also we do MVD with this approach. Mostly we do with field surgery in this case, in these cases. This is the conclusion. Using exoscope and endoscope, the viewpoint can be switched between outside and inside of surgical field to obtain a appropriate image. And these are advantages of exoscope. It is small, and it has a free visual access, and it is exchangeable to endoscope anytime. On the other hand, the disadvantages are still insufficient image for a highly magnified view and a deep and a narrow area. So it will be resolved by the endoscope, which has the advantages of wide viewing angle from a small entrance, and close-up observation and underwater observation. But it has a disadvantage of a clash of instrument with the endoscope. So ingenuity of tools and scopists will resolve the clashing problem. Okay, thank you for your attention.
Thank you.
Thank you, Professor Watanabe. It has been an excellent lecture. We're amazed with all the kind of pathologies you are treating with the exoscope and also with the endoscope. As you said, one of the disadvantages of the exoscope is when you have high magnification. I don't know if the detail of the surgical field is not precise, and also, as you said, the visual axis is out of alignment. Perhaps that's a disadvantage when you're trying to do vascular surgery, like treating aneurysm or any kind of pathology. Can you elaborate more about this? Thank you.
Thank you for your comment, Professor Salazar. Yes. I think it is, of course, possible to adapt to vascular surgery, but still, actually, I don't have much experience about vascular surgery. So, because at the end of the surgery of clipping, the angle of the applicator, so we need some space for the craniotomy. So, with a small keyhole, I have some, anxiety for finish the clipping. So, so far I'm doing tumor surgery with a keyhole endoscopic surgery.
Thank you, Professor.
Professor Juan Luis Gómez, please share us a little bit of your experience.
Yeah, thank you, Professor Salazar. Thank you, Professor Watanabe. I think we're all delighted with your excellent lecture. Definitively, we are living a new and wonderful area in neurosurgery. which requires adaptation, mastering of these techniques, even developing new techniques. And this also requires a re-education of we all surgeons to be comfortable using the endoscope. And the main difference is that you need to look at the screen. So for many surgeons, this is a very difficult stage in the development of these techniques. Definitively, I think we can save a lot of time using these keyhole techniques, adapting the exoscope and the endoscope in a simultaneous manner in order to save time and help the patient in a safe way to resolve the pathology. I think you have shown us the treatment of intrinsic and extrinsic lesions using these techniques. And definitively, I think this is going to be a powerful tool for the use in neurosurgery. Thank you very much, sir.
Thank you for your comment.
Thank you, Professor Juan Luis Gomez. Professor Allen Castro, please go ahead.
Hello, thank you, Dr. Watanabe. Excellent presentation, very new ideas, and we must keep in mind these new possibilities. My question for you is that a few years, like 5 or 6 years ago, we tested some first generation exoscopes and we saw it as a promising tool, but we didn't have the opportunity to use the new ones. And so I would like to ask you if you have experienced this progressive development of that and what you saw that was improved in these years in the exoscopes. And the second part of the question is that like endonasal surgery, many of the instruments had to be adapted or had to be redesigned to use that in endoscopic endonasal surgery. And in these surgeries that you may use the microscope, but you are using the endoscope, did you feel like needing new tools for doing surgery?
Thank you for a good question. Okay, the first question you asked about the progress in the quality of the exoscope right now. Yeah. Maybe 5 or 6 years, you use a 2D one or a 3D one?
2D.
Yeah. Yeah, there's a big difference between 2D and 3D exoscope because different from the endoscope, the eye is outside the surgical field, so we need a 3D at least.
Okay.
We need
perfect.
But even the 3D exoscope, still the visual quality is a little bit worse than compared to the microscope right now, but it is getting better. So now the Japanese exoscope, they're the so-called OI made by Olympus, is a little bit better than Stolz one, and maybe I think in this maybe several years, the next generation of exoscope is coming. So after that, maybe most of the microscope surgeon can shift to the exoscope. Mm-hmm. And the second question, that is a very important question. And as I said, when I do an endoscopic surgery, we need to bend the tip of the instrument frequently. So actually, our group developed the malleable but tough shaft dissectors. So it is very useful. So we need new tools to do a safe surgery with the endoscope. That is my answer. Thank you.
Thank you. Thank you very much.
Professor Joel Caballero, please go ahead. Your audio is out, Professor.
Thank you. Thank you, Professor Watanabe. A beautiful presentation. I have a question. We use the concept of 4 hands, 2 surgeons, not only during endonasal endoscopic surgeries. We use this concept during keyhole endoscopic surgeries. The question is, do you consider if there is advantage of the concept of 2 surgeons, 4 hands and dynamic magnifications over static magnification during these procedures?
Okay, thank you for your question. So you said forehand technique. Do you mean the moving of the scope, or a third hand or fourth hand inside the surgical field?
Yes, a second surgeon who keep the scope and perform dynamic magnification during the procedure.
Okay. Yeah. Exactly. You know, my surgery for keyhole endoscopic surgery is just like endoscopic endonasal surgery with the forehand technique. So the scopist is always moving the scope to make the comfortable situation, because there is a clash of the instrument with the endoscope anytime. So the scopist must take care the position of the scope. And sometimes scopist will insert the third instrument into the surgical field. So as you said, the forehand surgery is very important, not even, not only in the endonasal, but for the keyhole surgery also. Thank you.
Thank you for your answer.
Professor Watanabe, one final question. We all know that keyhole surgery has the limit of resolving or dealing with hemorrhagic lesions or hemorrhagic problems that can occur if some vascular lesion starts bleeding, or there is an unusual movement and some artery starts to bleed. So in your experience, how do you manage these complications in such short sites with the endoscope, and what's your percentage of times that you had to convert these keyhole approaches and exoscopic endoscopic approach to a conventional one?
Okay, thank you for the important question. So far, fortunately, I have never experienced the big problem with the arterial bleeding or something. But I have experience of venous bleeding from the sinus, or in the venous plexus inside the dura, by injuring by the endoscope there, the venous bleeding. I experienced some kind of a problem, but actually there's enough space to insert the instrument. We need only 2 by 3 centimeter keyhole. We can insert any instrument through the opening. So there's not so much problem to control the bleeding. So I think it is same as the conventional microsurgery. Just suck the bleeding point and just put the putty or the hemostatic agent to the bleeding point. It is just same as the microsurgery. And maybe the scopist will help the fogging problem, or the by changing the position of the endoscope, it will help the surgeon in such a situation. Thank you.
Thank you, Professor Watanabe. It has been a magnificent lecture with new points and new horizons regarding small approaches to intracranial pathology. Now we are going with the next speaker, Professor Takeo Goto. We would like to introduce Professor, who is co-chairman of the World Federation of Neurosurgical Neuroendoscopy Committee. He's going to talk about surgical strategy of endoscopic school-based surgery. Welcome, Professor Takeo Goto. Please go ahead.
Thank you, Professor. Can you see my slide?
Yes, it's okay.
Okay. Today, I feel very honored to have opportunity to present my work in front of the many experts of the neurosurgeons. Today, my topic is a surgical strategy of endoscopic skull-base surgery. At first, I will introduce my institute and me. Department of Neurosurgery, Osaka City University is one of the largest skull-base centers in Japan. So my old mentor, Professor Hakuba, started the transcranial skull-base approach to resect the skull-base tumor. And my mentor, Professor Ohata, and I also use the transcranial skull-base approach. But recently, endoscope can offer the panoramic, wide, and clear view in deep surgical field, and which largely contribute to less invasive tumor removal. So today I present the endoscopic endonasal approach and also endoscopic keyhole transcranial approach to skull-base tumors. At first, I will present endoscopic endonasal approach. Of course, I know that many skull-base tumors can be safely resected by the transcranial skull-base approach like this: frontal-basal, orbitozygomatic, anterior or posterior transpetrosal, or suboccipital approach. But if the region are located pure central skull-base within this circle, which connecting all cranial nerves, surgical resection by the transcranial approach seems to a bit difficult or challenging. But endoscopic endonasal approach dramatically changed this situation. If we observe this circle through the endonasal route, the only obstacle to access this area is a bony structure, such clivus, pterygoid bone, and petrous bone. So if we adequately drill out this bony structure, we can directly access within this circle without getting over the cranial nerve or vessel. So I will show the several cases. This is a retrochiasmatic craniopharyngioma and show the posterior fossa extension. But if we access this tumor by the endoscopic endonasal approach, we can directly access within the circle of Willis. Of course, to reach the lateral part of the tumor, bilateral posterior clinoid is the main obstacle. But if we drill out this bony structure, we can completely expose entire area of the circle of Willis. So we can resect the tumor safely. I will show surgical video. At first, I widely drill out the bony structure around the cella floor. And this is a pituitary stalk, and this is a posterior clinoid, and this is a dorsum cella. I carefully drill out the posterior clinoid on the right side. And then I dissect the pituitary gland from the medial wall of the cavernous sinus and mobilize the pituitary gland to the left side. And I cut the dura mater around the dorsum cella. This is a basilar artery and a P-cone, and this is a oculomotor nerve. This is a pituitary stalk, and this is a tumor. Using this approach, we can directly observe the border between tumor and neural tissue. And in this surgery, the four hands technique is very important for careful dissection of the tumor capsule from the critical neurovascular structure. I carefully follow the border between the hypothalamus, and finally, all tumor was successfully resected out, with preservation of the pituitary stalk and gland. Postoperatively, tumor was totally resected out. Her vision also improved. This is another case of the large diaphragmacellar meningioma. Attachment of the tumor is diaphragm, and the tumor was very large and compressed hypothalamus. How to resect this tumor by the transcranial approach? But if we access this tumor through the endoscopic endonasal approach, we can directly access the attachment of the tumor. So I use the endoscopic endonasal approach. After widely drill out the bony structure, I mobilize the pituitary gland to the right side and then reach the diaphragm. This is the attachment of the tumor. So at the initial stage of the surgery, we could detach and devascularize the tumor. So we could gently dissect the tumor capsule from the critical structure. This is a PCOM and perforator from the PCOM. To meticulous surgical procedure, four hands technique is very key point. And then this is the inferior surface of the optic chiasma. I gently retract and dissect. And finally, all tumor was successfully resected out. After the tumor removal, we have to watertightly seal the dural defect. In such situation, I insert the fat tissue to subdural layer and put some stitch. Of course, in some case, watertight closure, of course, very difficult, but to put some stitch was very useful to fix the fat tissue. And then cover the large mucosal flap. Finally, the old tumor was safely dissected out, and this is a mucosal flap. So we could prevent the CSF leakage and visual and memory disturbance dramatically improved. This is another case of the tumor arise from the posterior clinoid. Attachment of the tumor is posterior clinoid. So tumor located within the circle of Willis. So I choose also endoscopic endonasal approach. This is a pituitary gland, and this is a carotid artery, and this is a posterior clinoid process. I carefully expose the posterior clinoid on the right side, and then carefully drill out. To widely expose the posterior clinoid, I gently mobilize the carotid artery to the right side. And then this is the attachment of the tumor. So I cut the attachment and coagulate. So tumor already devascularized and detached. So we could resect out the tumor very bloodless surgical field. We not encountered bleeding from the tumor. Already tumor was devascularized and detached. So I carefully dissect the tumor surrounding the structure. This is the oculomotor nerve, PCA, and PCOM, and pituitary stalk and gland. So posterior clinoidectomy was very useful to this tumor. And finally, all tumor was successfully resected out without any deterioration of symptom. This is another case of the lower clival meningioma showing the right facial spasm. How to operate this case? If we choose the transcondylar approach, there is some risk to damage the lower cranial nerves. Or if we choose the combined or anterior transpetrosal approach, we have some risk to damage the abducens nerve. But if we access this tumor by the endoscopic endonasal approach, we can directly access the attachment of the tumor. So I choose the endoscopic transcribal approach to this tumor. I will show our surgical video. At once, I widely drill out the bony structure. This is a jugular tubercle, and then I cut the dura mater. Already tumor attachment was devascularized. So we could perform the internal decompression in very clean surgical field. And this is a medulla oblongata, and this is a tumor. This is a basilar artery. I carefully dissect the tumor from the brainstem and perforator. In this approach, a tumor already devascularized and detached. It's very important strategy to this skull-based tumor. This is a vertebral artery, and this is a tumor. This is a tumor ventral side of the lower cranial nerve. I carefully resect it out. Then go to the lateral side of the tumor. This is a abducens nerve, and this is a lateral attachment of the tumor. I carefully resected out the tumor and confirm that this is a 7th and 8th nerve. So I confirm that most part of the tumor was successfully resected out without any retraction of the cranial nerve. Post-operatively, tumor was successfully resected out and decompressed, and her facial spasm improved and then disappeared. This is another case of the recurrent lower cribus meningioma. Attachment of the tumor is here, so I choose the endoscopic transcribal approach. I carefully drill out the lower cribus and expose the dura mater behind the cribus. Wide bony drilling is very important to perform the early devascularization and detachment of the tumor. And then I cut the dura mater and then go to the subdural space. Fortunately, this tumor was very soft, so we could gently dissect the tumor from the cranial nerve or brainstem. I gently dissect the tumor from the vertebral artery and then dissect the tumor from the abducens nerve. Gently, I carefully follow the tumor capsule and dissect. This is the icon, and this is the lower cranial nerves. Endoscope could offer the direct view between the border and tumor and surrounding critical structure. This is a tumor around the pontomedullary junction, but I carefully removed, and this is a facial nerve. So now the almost all tumor was successfully resected out. If we choose the transcranial approach, we have some risk to injure or damage the lower cranial nerve. But through this approach, we could safely resect all tumors. Post-operatively, we could resect tumor totally without any deterioration of symptom. Then I will explain the endoscopic keyhole approach. One is endoscopic subfrontal, and the other is endoscopic subtemporal approach. I will show the anatomy of the endoscopic subfrontal approach. At first, I put skin incision around the eyebrow and put the craniotomy with the size of 3 centimeters, and then insert the endoscope to the frontal base. Under the endoscopic view, craniotomy was small, but we could observe the olfactory tract, proximal sylvian fissure, and then I could observe the carotid artery, oculomotor nerve, and then if we move the endoscope more medial side, we could expose the optic chiasm, tuberculum sella, and drill out the optic canal. So I apply the subfrontal keyhole approach to this tuberculum sella meningioma. At first, I perform the craniotomy with the size of 3 centimeters, and then gently insert the endoscope to the subfrontal space. Brain retraction was very small, but at first we can directly access the attachment of the tumor. And then I drill out the tuberculum cella and also open the left oblique canal. This is a left oblique canal, and then I open the oblique canal at the initial stage of the surgery, and then start the tumor removal. This is a left oblique nerve. Using this endoscope, we could observe the medial surface of the oblique nerve. This is a blind spot of the microscopic unilateral approach. But using the endoscope, we could observe the whole area around the tuberculum cella and then remove the all attachment of the tumor. So I confirm the Simpson grade 1 resection was performed. Postoperatively, the whole tumor was safely resected out. This is another case of the relatively large olfactory groove meningioma. I think the endoscopic keyhole approach was good indication to this kind of tumor. I cut the skin incision around eyebrow and perform the craniotomy with a size of 3 centimeters like this. And then insert the endoscope. This is a frontal base. I cut the dramata along the frontal base and perform the drilling out the hyperostotic bone and then coagulate the attachment of the tumor. A basic concept of the skull-based surgery is to access the attachment and origin of the tumor. After devascularize and detach the tumor, we could safely mobilize the tumor of the neural structure. This is a frontal base. I carefully perform the internal decompression. Using the endoscope, brain retraction was very small, but we could get the wide panoramic view around the frontal base. And now I confirm the tumor was completely detached. And then continue the tumor removal. And finally, we expose the optic nerve. And tumor attachment was completely removed out. And finally, I dissect the tumor from the right olfactory nerve like this. And then tumor was totally resected out, include the attachment of the tumor. Postoperatively, all tumor was safely resected out with the preservation of the olfactory function. Then I will show the anatomy of the subtemporal keyhole approach. If we put the small craniotomy around the temporal area and insert the endoscope, endoscopic panoramic view can offer the good view around the tentorial edge. This is a oculomotor nerve tentorial edge, and then we could expose all branch of the trigeminal nerve, and then we could open the Meckel cave and expose the Gasserian ganglion. So after this cadaveric study, I applied this technique to the medium or small size of trigeminal schwannoma. To this case, I put small craniotomy to the temporal side and insert the endoscope. At first, I put the craniotomy around the temporal side and then gently retract the temporal lobe. Then we carefully insert the endoscope. This is a frontal base, temporal base of the right side. And this is a dramata over the trigeminal nerve. I cut the dramata, and this is a SPS over the Meckel cave. I coagulate and cut the SPS and to open the Meckel cave. After coagulation of the SPS, we could open the Meckel cave under the endoscope. And now I dissect the tumor from the trigeminal nerve. To careful dissection of the tumor, also Hofmann's technique is very important. Scopists use another instrument and retract the tumor or protect the critical structure. And then finally, all tumor was successfully resected out. This is a posterior fossa. So we confirm that all tumor was successfully resected out. This is another case of the recurrent chondrosarcoma associated with osteogenesis imperfecta. For her bone disease, she shows a basilar invagination, so the angle of the temporal base and the tentorium was very steep. So to see the top of the tumor, I use the endoscopic subtemporal approach. After the insert to the endoscope, I gently retract the temporal lobe. And then we can reach the tentorial edge. This is a trochlear nerve, and this is a tentorium, and this is a trigeminal nerve. Under the endoscope, we can get very clear surgical view around the brainstem, and then I carefully resect the tumor piece by piece. Tumor was very fibrous, but high magnification and good view under the endoscope was very useful for meticulous dissection of the tumor from the brainstem. This is a brainstem, and this is a tumor. I carefully dissect. And finally, resected out all tumor very carefully. This is a trigeminal nerve, brainstem. So endoscope was very useful to this case. Finally, all tumor was successfully resected out. This is another case of the falcotentorial meningioma. Her age was relatively old, so I consider the less invasive procedure to this tumor. If we insert the endoscope posterior interhemispheric fissure, I think it's possible to cut the falx and coagulate along the tentorium. After that, we can safely resect out this kind of the tumor. We place the patient in the lateral position and insert the ventricular drainage, and then put the small craniotomy. This is a midline, and then I insert the endoscope. This is a falx. At first, I coagulate and cut the falx to devascularize and detach the tumor. In all cases of the skull base or meningioma case, devascularization and detachment is key point to safe resection of the tumor. This is an attachment around the tentorium, and then performs the internal decompression. Recently, the CUSA was very useful for quick or safe devascular removal of tumor, and I coagulate the attachment of the falx and the tentorium. This is a falx, and this is a tentorium. I carefully cut the tentorium on both sides, and finally, we could gently mobilize the tumor of the critical structure. This case, a large collateral vein running the right side, so we have to carefully preserve this deep venous structure. But now, tumor was already devascularized and detached, so we could clearly identify the collateral vein on the right side. So we meticulously and safely preserve this collateral venous channel. And finally, I rejected out all tumor under the endoscope. Now I confirm that all tumor was rejected out and venous structure also preserved. Craniotomy was very small and brain retraction very minimal. So I think that this is very less invasive for her. Post-operatively, the tumor was totally resected out, and there is no another complication to her. So endoscopic interhemispheric transtentorial approach was very useful. So today I will present the two surgical endoscopic procedure. One is endoscopic endonasal approach, and the other is endoscopic keyhole approach. I think that these procedures can be very effective procedure for removing the complicated skull-based tumors. Thank you for attention.
Thank you very much, Professor Takeo Goto. It has been a wonderful lecture, very impressive. You have explained perfectly both techniques, the endonasal technique and also the several approaches to the cranial base, with the emphasis on preserving the vascular and neurological structures with a splendid technique. I would like to ask you about the specialization of this cranial base in your country. How is the program constructed? How many years do you have a program to specialize in cranial base surgery to perform this kind of surgeries like you do?
Thank you, Professor. I joined skull-based surgery for already 15 years. At the first 10 years, I performed the transcranial skull-based approach, and then gradually moved to the endoscope. Now I choose both technique, transcranial and endoscope. In my feeling, the difference between the transcranial microscopic surgery and endoscopic surgery, surgical technique not so different. So I recommend the young neurosurgeon to treat the skull-based tumor. It's better to learn the both techniques at the same time.
Thank you, Professor. We would like to have comments or two experts on these techniques. Professor Luis Felipe Alencastro, please.
Well, Dr. Goto, thank you very much. It's a very nice lecture, wonderful lecture, because you had shown us very difficult cases and many possibilities. Of course, many of these tumors we are seeing in the meetings and other places, many discussion about which technique to choose, microscopic, endoscopic, combined. And I would like to ask you, I think first of all that we must have both tools in our hands, and we must learn both tools to select the best for the patient. I would like to ask you, how do you select each case? What are the main things, or one or two things you use to select the patient for microsurgery or endoscopic surgery? You have shown us, for example, Endonasal is very clear about leaving the nerves outside. But when you go for intracranial, we use a lot the supraorbitary approach with the microscope, and then using the endoscope in the end to check and to see or to complete. But how is your selection? How is your selection is the question. Thank you.
Thank you, Professor. Good question. I have the one concept to skull-based tumor to access the origin of the tumor without crossing over the cranial nerve and vessel is very important. For example, the Cavernous meningioma was even the Cavernous meningioma very large, but if we choose the endoscopic transcranial approach, we can directly access attachment of the tumor without crossing the vascular or neural structure. In such situation, I choose the endoscopic transcribal approach. But in case of the petroclival meningioma, attachment of the tumor usually very wide, in some cases attached to the petrous bone. So if we access this tumor by the endoscopic endonasal approach, some attachment of the tumor is behind the abducens nerve. In such situation, endoscopic approach will not good. So I choose anterior transpetrosal or suboccipital or combined transpetrosal based on the size or location of the tumor. So anyway, I always consider which is the best way to access the origin or attachment of the tumor. This is my concept to select the surgical approach.
Thank you.
We also would like to know the comment of Professor Juan Luis Gomez Amador. Please go ahead, Professor.
Thank you, Professor Salazar. Professor Goto, I really thank you for your excellent presentation. I think you have shown us what the modern skull-based surgeons should be, mastering the endoscopic techniques and also using the microscopic techniques or a combination of both. I think we should encourage the young generations to go to the laboratory in order to understand this precise osseous dissection that you are performing, particularly to the posterior fossa approaches using the endoscopic endonasal approaches, and also to make a very careful emphasis in the reconstruction techniques in order to avoid the CSF fistula. I think the best way to treat your clival meningiomas is effectively to the endoscopic endonasal approach, because then we are working in the middle of the nerves. So we don't disturb the nerves, particularly the sixth cranial nerve. So we have some experience using also this approach for the treatment of the clival meningiomas. And when they are located just in the middle line, I think this is a perfect approach because it's a very easy approach using proper techniques to perform a transclival approach. And then, as you show us, we are using the principles of microsurgery: exposition, early the vascularization of the tumor, and obviously the preservation of the neural and vascular structures around the tumor. So I think the future for clival meningioma probably is using the endoscopic techniques. I saw some years ago Professor Theo from Australia showing that, yes, showing that this technique will be useful even for the treatment of large petroclival meningiomas using a combination of techniques: endoscopic endonasal for early decompression of the tumor, and perhaps a combination with a retrosigmoid approach for the remnant part in the lateral position. I think this is a very good combination of techniques. I really thank you for your cases, and congratulations for your excellent lecture.
Thank you for the good comment. I agree with your opinion. I also the endoscope from the Charlie Theo in Australia, so I know his concept. Of course, if we combine the endoscopic transcribal and suboccipital approach by two stages, of course, we could reject the petroclival meningioma, I think. Thank you.
Thank you, Professor. I would like to ask you some question of debate. We have seen so many masters like the ones we have in here, like Professor Juan Luis Gomez, Professor Allen Castro, and so many others. And I guess there is no consensus regarding the use of lumbar drainage for keeping the cerebral relaxed, and of course the risk of infection. And we know that, you know, when we can follow the tumor, we are going to follow the tumor to the base and try to do an excellent dissection as you have demonstrated. But for that, I would like to ask you, what's your method in your clinic? Do you use a lumbar drain? What considerations would you like to, or can you share with us so we can have a relaxed brain and get to do all the things that you have shown us?
Thank you for good question. During the surgery, control the intracranial pressure very important. So when I use a keyhole approach, a keyhole subfrontal or keyhole subtemporal, I use a lumbar drainage. But endoscopic endonasal approach, I don't use lumbar drain. So especially subtemporal approach, at first it's very difficult to release the CSF. So I recommend to use a lumbar drain for gentle retraction of the temporal lobe. It's my comment. Thank you.
Thank you, Professor Goto. I would like to give some comments from Professor Igor Facchini from Brazil. Please go ahead.
Thank you, Professor Goto. Excellent lecture. Hello, my friends. Thank you, Professor Goto. Excellent lecture. I have 3 questions very quickly. First one, about the learning curve. How many cases do you think, Professor, a neurosurgeon should do before master the technique? And if there are any special cases that you recommend for the young neurosurgeon to start with? The second question is if you ever had any major bleeding in which you had any difficulty to control. And the third question is about the time of the surgery. If you think that the length of the surgery is the same using the endoscopic technique, or if you think that the microscopic technique is faster, or if you think it is the same thing in terms of surgical length. Thank you very much. Excellent lecture.
Thank you for your question. What was what is the first question?
Well, the first question is about the learning curve. How many cases do you think someone needs to do before?
I understand.
Yes.
I think the anatomical understanding is easier the endoscopic technique, but learning curve is the same. At first, we have to learn the anatomy of the skull base, even the endoscope and the transcranial. So if some use a cadaveric study, I think their learning curve is very steep. But not understand the anatomy of the skull base, learning curve not good. So in our institute, about 4-year program to become the surgeon to endoscope. So I think the 4 or 5 year is required to master the endoscopic surgical technique. Another question is, of course, I have the one case of the carotid injury during the endoscopic endonasal approach. But in such situation, the whole hands technique is very important to find out the bleeding point. And fortunately, in this case, we could safely stop the bleeding from the petrous carotid artery, and the patient not show the complication after the bypass surgery. So I think the endoscopic technique, the whole hands technique is very safe procedure to control the bleeding or to dissect the musculus procedure. What is the third question?
The third question is about the surgical time. If you think that the time of the surgery is longer when you do the endoscopic technique when compared with the microscopic technique, or if you think it's the same.
In my feeling, surgical time is shorter than the surgical time of endoscope is shorter than the microscopic surgery because the size of craniotomy is small and no need to stitch the large skin flap. So totally, I think the surgical time is short in case of the endoscopic surgery.
Thank you, Professor.
Thank you, Professor Goto. It has been a wonderful lecture. Now, continue with our last lecturer. We would like to present the work from Professor Komatsu Fuminari with his lecture about endoscopic microvascular decompression for trigeminal neuralgia and hemifacial spasm. Please, thank you.
Thank you for the invitation to this video seminar. I'm Dr. Komatsu from Fujita Health University Bantane Hospital in Japan. My topic today is endoscopic microvascular decompression for trigeminal neuralgia and hemifacial spasm. Successful microvascular decompression requires two elements: precise identification of neurovascular conflict and appropriate decompression. The endoscope provides panoramic views even in the deep surgical field with minimally invasiveness. Transposition technique is a desirable method for long-term outcomes. In our institute, fully endoscopic microvascular decompression is performed. The patient is placed in park bench position. After making a 3 cm skin incision, a 2 by 1 cm keyhole is created at transverse sigmoid junction. The same keyhole is made for trigeminal neuralgia and hemifacial spasm. The endoscope is fixed at pneumatic endoscope holder, and bimanual technique is performed. Single shot instruments are used. Brain retractor is not used. The compressive procedure is classified into two methods: interposition and transposition. For interposition, the prosthesis is placed between the cranial nerve and the offending artery. In contrast, the transposition, the offending artery is moved away from the cranial nerve and fixed at the dura with fibrillin glue and Teflon felt. Interposition is technically easier, but the recurrent rate is higher than transposition. In contrast, transposition is technically difficult, but the desirable method for long-term outcomes. And next, the anatomy of the endoscopic retrosigmoid approach is shown by cadaver dissection. The endoscope is inserted to the retrosigmoid keyhole, and then the endoscope proceeds the tentorial surface of the cerebellum. Now we can see the trigeminal nerve, SCA, and the superior petrous vein. Also, the third and fourth nerves are visible. The 30-degree endoscope will visualize the course of the trigeminal nerve. Also, the cranial nerves are visible, and behind the trigeminal nerve, the sixth nerves and the basilar artery are visible. The 30-degree endoscope also visualizes the medial cave. Surgical cases of the endoscopic microvascular decompression are shown. The first case is the left side trigeminal neuralgia caused by the SCA. In this case, the rostral trunk of the SCA making a small loop and compressing the trigeminal nerve. For this case, simple transposition method is performed. Now the trigeminal nerve is partially visible behind the superior petrosal vein. The trigeminal nerve is compressed by the caudal trunk of the SCA. The SCA is moved away from the trigeminal nerve and fixed at the tentorium with fibrin glue. Complete decompression is achieved. This is a case of the simple transposition. The next case is also trigeminal neuralgia caused by the SCA. But in this case, the rostral and caudal trunks of the SCA are making a deep loop and compressing the trigeminal nerve. For this case, the compressed transposition is required. This is the video. The trigeminal nerve is compressed by the deep loop of the SCA. Here the distal part of the SCA. First, the distal part of the SCA is lifted with the sagittal ball, and the loop of the SCA is pulled out. We can see the motor root of the trigeminal nerve, and then the caudal trunk of the SCA is pulled out and fixed at the tentorium. The rostral trunk is also fixed with the same fashion. The offending arteries are disappeared from the view and complete decompression is performed. This is the case of the complex transposition. Next case is the trigeminal neuralgia caused by the ichor and the vertebral artery. The trigeminal nerve is directly compressed by the ichor and indirectly compressed by the vertebral artery. The video is shown. The trigeminal nerve is compressed by the ichor. Also, vertebral artery is visible behind the ichor. Clear indentation of the trigeminal nerve is visible. Decompression procedure is started from the vertebral artery. The vertebral artery is moved medially and fixed with the fibrin glue. Also, the transposition is reinforced by the Teflon felt. Then the ichor is transposed and fixed at the petrosal dura. Also, the SCA running near the trigeminal nerve is transposed, and this is the final view of the decompression. One of the possible complications during the endoscopic microvascular decompression is venous bleeding from the superior petrosal vein. Venous bleeding from the superior petrosal vein must be controlled properly even under endoscopy. Here is a video of the management of the venous bleeding from the superior petrosal vein. The venous bleeding is started. The irrigation and suction is continued to clear the surgical field. And two surgical balls are used for the management of the venous bleeding. The first sagittal ball is placed behind the superior petrosal vein. It works for the scaffold of the second sagittal ball, and the second sagittal ball is placed in front of the superior petrosal vein. Now the superior petrosal vein is completely covered with the sagittal balls. After waiting several minutes, the bleeding is controlled. Hemostasis is achieved. The sagittal balls are removed, and the clear surgical field is maintained. The next case is the hemifacial spasm caused by the ichor. The keyhole is made at the transverse sigmoid junction. It is the same as trigeminal neuralgia. The arachnoid membrane is opened and the 0-degree endoscope, and then 30-degree endoscope is applied to visualize the facial nerve. Ichor and the vertebral arteries are visible. After mobilization of the ichor, RVG of the facial nerve is well visualized. The offending artery is moved away from the facial nerve and fixed at the petrosal dura with fibrin glue, and decompression is reinforced with Teflon felt, and complete decompression is achieved. The next case is a hemifacial spasm caused by the pica and the vertebral artery. After opening the arachnoid membrane, the 30-degree endoscope is applied. The facial nerve is compressed by the pica and the vertebral artery. Indentation is well visualized. The decompression procedure is started from the vertebral artery. A few pieces of the Teflon felt is placed between the vertebral artery and the brainstem, and then the Teflon felt sling is passed under the pica loop. One side of the Teflon felt is fixed at the petrosal dura, and then another side is also fixed at the petrosal dura. Complete decompression is also achieved in this case. Endoscopic microvascular decompression allows reliable identification of neurovascular conflicts with minimally invasiveness. Endoscopic microvascular decompression with transposition is technically feasible, and using the fibrin glue is a simple and safe method for fixation of transposed arteries. endoscopic microvascular decompression. This transposition is expected to offer excellent long-term outcome. In conclusion, endoscopic microvascular decompression, this transposition is expected to offer excellent surgical result. Thank you for your attention.
Thank you very much. We would like to start the discussion about this last lecture. I would like to know
the experience of Professor Feres Chadat, if it's still here, regarding his experience in this neurovascular conflict. Professor, how do you manage these vascular pathologies?
Are you asking Dr. Komatsu?
And Professor Chadat.
Okay, sorry.
Well, Professor Kato, maybe you can also help us with your experience in these vascular conflicts, how you deal with these pathologies.
I don't know if you heard the question, Byron.
Professor Kato.
Yes.
Yes, can I ask you a question?
Yes.
I would like to know how you deal with these complications. Yeah.
Yes, I think especially the hemifacial spasm is when we deal with open surgery, it's quite difficult to see the root exit zone because some muscle or some other the usual pathology. So I think this technique is more advantage to the hemifacial spasm because we can see very clearly of the reds. And also sometimes I want to ask some endoscopic specialists, when you do not see any cause for trigeminal neuralgia, how would you like to treat? This I want to ask Luis or some other specialist. Byron?
Yeah, I can speak, Byron. We have started doing, we started doing endoscopically treatment for Trigeminal Neuralgia or for visual spasm in back 2005 or 2006. We made a course in Porto Alegre with Dr. Larigan Shaker that by that time was introducing or was using much of this concept of endoscopic, totally endoscopic surgery for these pathologies. And we made many cases for that. But third time, we didn't realize much advantage of this technique over the microscopic traditional technique because the size of the bone removal was almost the same, the dural incision was almost the same, and in our hands we could have more maneuverability with the microsurgical technique with the microscope. But almost 100% of the cases nowadays, we use also the endoscope before putting our Teflon to isolate the nerve from the artery. And also after putting the Teflon, we use the endoscope to see. And in more than one case, we could see something new. We could see some extra point of compression besides that the first one we have seen in the microscope. So I think endoscope is very useful in MVD, but I believe at our hands that microscopic assisted with endoscopic and not endoscopic, purely endoscopic in nowadays.
Byron, sorry, I am having problem with the patient, sorry. But in this type of surgery, I use, in all surgeries that people showed, I use the microscope. The microscope is a part of my body. I love to use the microscope. I have the ability to use the microscope. It's very, very important. I don't need to change to use the microscope. I love to use the microscope. In all cases, yesterday I operated a craniopharyngioma to invade the third ventricle. I used the interhemispheric, transcallosal, transchoroidal. I removed all tumor. All. I love to use the microscope. It's very important. It's the most important instrument of the neurosurgery is the microscope. It's the microscope. I love to use the microscope. Sorry, everybody, but I love to use the microscope. I was quiet until now, but I love to use the microscope. In these cases, I use the semi-seated position. I use the open microsurgery, the open surgery. Thank you, but I love the microscope. Okay, I don't use the endoscope. Some cases, I use the endoscope. In most of my cases, tumor, aneurysm, AVMs, cavernous malformation, I use the microscope.
Thank you, Professor Feves. Professor Cato commented, what do you do when you don't find this microvascular conflict? Sometimes we can find some kind of fibrosis, membranes, adherences that are compressing the nerve. So one of the first steps to go into the nerve is to take out this kind of adhesions, membranes. And I personally prefer the interposition technique over the transposition because sometimes you transform the artery or the vein, sometimes there are veins also, and then can go back to the same position. So I prefer the interposition and to put the Teflon, and after the Teflon, sometimes we put some kind of bio glue to fix the Teflon in its place. So that's part of my experience. Perhaps I would like to have the comments, Professor Juan Luis Gomez Amador also.
Thank you very much. So recently for the trigeminal neuralgia, if there is no reason and no cause, so sometimes we cut some fibers or some, of course, some combing, or of course the release adhesion, etc. And also the prosthesis insertion or transposition issue. I think in our institute, almost 100%, we want to try to transposition. But sometimes very small, tiny perforators going to the brainstem. So for that case, sometimes we use Teflon with some short distance. Then, but anyway, the transposition is much easier, and so far we don't have a recurrent case. So and also endoscope, because I'm a microscopic neurosurgeon. I love the microscope, of course, just like a verse, of course. But this endoscopic procedure is much shorter the time, duration of the time, and also very less invasive because of the post-operative patients complaining very, very small, almost zero. And also very high illumination and high resolution. I think maybe in the future, with Stolz endoscope, we have ICG, so then we can check the vascular complication we can avoid, I think. Thank you very much for your valuable comments.
Thank you, Professor.
Thank you,
Professor. Professor Juan Luis Gomez Amador, we all know that you love endoscope. So what would you do? What would you like to share with us with your experience in these MBD transpositions?
Yes, sir. As I mentioned before, we're living a new area of neurosurgery. I also love microscope because a microscope is part of the of the techniques the surgeon need to use for treating several pathologies. But also we must be aware that the new advancements in the visualization and the quality of the image through the endoscope is giving the surgeon a new perspective and new windows in which we can use the endoscope just as a tool, as we are using the microscope. One very important thing is that when we are using the microscope, it is not just to bring the microscope to the operating room and have tiny instruments to treat the patient. The using of the microscope involves a whole philosophy, and this is the same for the endoscopy. So endoscopy is not just to bring the endoscope to the surgical field. It's a philosophy, how to preserve structures, how to manage different pathologies using endoscope, microscope, or both instruments. What I appreciate a lot from the lecture is that, as in the previous lectures, we have seen that this is for our young surgeons, proper knowledge of the anatomy using cadaveric dissections in a laboratory is mandatory for the education of the new surgeons. And also, as we have seen in the lectures, there is a special need to have a proper analysis of the preparative image in order to apply these techniques that we have learned before in the laboratory, so we can apply it to the patient. And I think particularly in these cases, the endoscope brings a wonderful view, and it is very factible to be used for trigeminal neuralgia and hemifacial spasm. I agree that the microsurgery is the conventional technique for this, but we need to be open all the time to the new technologies, to the new techniques, so we can use it properly for the treatment of our patients. Thank you very much for your lecture, Professor Camacho.
Maybe Professor Goto, you can give us some comment, please.
Thank you. I'm very happy to this meeting. I have just one message to the young generation. In the field of skull-base surgery, microscope and endoscope is just a surgical instrument to see the pathology. So in some situation, we need the microscope, and in some situation, we need endoscope. So we have to learn both technique, microscope and endoscope even. So based on this training system, anatomical understanding is key point to learn the skull-base surgery. So whole young generation, please study the skull-base anatomy is a key step to brush up your technique. It's my only comment for young neurosurgeon. Thank you. I'm very happy to join this meeting.
Thank you, Professor Goto. Professor Alan Castro, please go ahead.
Hi, thank you, Barry. I have another point that just go to complement what Dr. Gomez Amador and Dr. Goto said. I think that the new generation must be able to deal with or to know to treat patients with both techniques, because only in this way we can choose the best for the patient. Of course, we can do many things in the endoscope, and we see many times some people exaggerating in one technique or in other technique. So I believe that we must be very balanced and must be master in both techniques because they are complementary many times. And many microscopic surgery are the use of the endoscope is beneficial. So you must know how to use both, so you don't have a bias for selection when you have a case in front of you. You have to know both techniques, and then you choose the best. Of course, you must use the best that you can offer the patient the best results. If it's the microscope of the endoscope, what matters is the result for the patient, period. So And I agree with, I know all the capabilities of Dr. Ferris Shadat because he's a master in microscopic surgery. So for his hands, maybe the microscope will make the solution for most of the things. But I think that the new generation must be able to treat patients with both techniques so they can select the best one for each patient. That's my point of view.
Thank you, Professor Ancastro. And yes, I agree a lot with you and with all the panelists, because the turning point from going to microsurgical to endoscopical, I think it's a little bit big, you know. And I guess we have to first master the neurosurgical techniques. So, and you know, step by step, getting into harder cases in school-based neurosurgery. I know as a young neurosurgeon, we have many issues with the fistula, no? A CSF fistula, because maybe in wider craniotomies, we can water tight the dura and we avoid the fistula problem. And with endoscopic or pure endoscopic approaches, when there is a small hole and then we try to use some gel foam or some hemostatic agents to put some muscle and bioglue and something like that to avoid fistula. And I guess it's a learning curve to get to the hands of Professor Juan Luis Gomez or Professor Ancastro to get, and or like as we have seen from Professor Goto, to this kind of neurosurgical mastery with endoscopic techniques. Yes, Professor Ancastro.
I'm sorry for talking too much, but this is something that I see many times. Young people, there is another point that Ferris has the reason when he talks about the learning curve, because we make, as is natural, that we make much more microscopic surgery than endoscopic surgery. So our learning curve with the tool, with the microscopic tool, is much faster than the endoscopic learning curve, because we have we have less cases for the endoscopic arm of this learning curve. So the danger in the endoscope many times is with new people that they made 10 or 15 endoscopic pituitary surgeries, and they may think they are enabled to make an clival meningioma or a tuberculum cella meningioma. So it's not with 10 or 15 or 100. Of course, everyone has its own curve, but believe me, the learning curve of the endoscopic arm of this learning curve is longer than the microscope, because we use the microscope much often than we do in the endoscopic. Just pay attention on that.
Thank you, Professor. Professor Cato, I would like to finish the. Igor Facchini has left his hand up. Igor.
I have a technical question for all the panelists. It is about the technique that you use in the vascular conflict. If you just put the Teflon between the nerve and the vessel and put some fibrin glue, or if you also do a sling in the vessel with an 8/0 suture and stitch it in the tentorium or in the petrous bone dura in order to avoid a future contact between the nerve and the vessel, which kind of technique do you use? Just Teflon or Teflon and the sling in the vessel? How do you deal with that?
So in our institutes, almost 100% now is just attached to the vessel transposition to the dura with fibrin glue. So no more Teflon, etc. So sometimes it, of course, may cause some infection or some recurrence. So I think it's very easier, faster technique, I think. Maybe some other panelists.
Thank you very much, Professor. Oh yeah.
For Dr. Komatsu, I have a question, because many people talk about the problem or the possibility of fibrous reaction when you inject fiber glue near the nerves in the posterior fossa. We have seen some glues that are more appropriate for that, or some that are not, and some that are absorbable. So once they are put there, sometime later they get out of place. So theoretically the transposition would be failed. So I would like to hear for his opinion about this fibrous reaction, or this inflammatory reaction that can happen in the posterior fossa around the nerves using fibrin glue.
Maybe Professor Kato, you can help us with that question.
Sure.
So, sorry, so this time Dr. Komatsu is an emergency surgery, so
okay.
Yeah, we work together. I think maybe still, of course, it will be disappearing. It is said in the literature, but 5-6 years recurrent case, still the Teflon is sitting in between the vessel and nerves. I think we do not have any pathological findings, but it looks like seems some infectious part of the in between the nerve and the vessels, I think. Professor Goto, any comment? Thank you.
Thank you. Thank you.
Goto Sensei.
Well,
so
any infectious influence the Teflon by Teflon insertion?
In our institute also, I not use Teflon around the cranial nerve. Teflon in some case causes a granuloma. So just mobilize the artery and fix the tentorium by the fibrin glue only. In some situation, of course, we use Teflon, but always keep away from the cranial nerve. This is my
thank you, Professor. Thank you. Well, if there is any no other comment, I would like to thank you all for being here tonight. I would like to have our final remarks from Professor Yoko Kato, and then I would like to give the word to Oriel Vega so he can make a small announcement. Professor, please.
Yeah, thank you very much. Japan is it's almost noon time, so it's the best time for us to present our papers. So it is our great honor to be invited. I think these 4 endoscopic neurosurgeon is just representative of the Japanese endoscopic society. So I think in the future we like to some collaboration. Maybe some the treating way is maybe a little bit different. But I think sometimes a good gate for YNS, young neurosurgeon, to use the endoscope for posterior fossa lesion, I think. Thank you very much, the Professor George, and also the Dr. Byron, of course, that he organized everything, and Dr. Luis and the Joan, and also the Igor. Many times that he gave us some good lectures. And thank you very much for tonight's invitation. And we should collaboration in the future more and more. Thank you very much.
Thank you so much, Professor. Uriel, yeah, you can have the word right now.
Thank you, Dr. Byron. Well, I'm so sorry because for my house it's raining a lot and there was a blackout. But I will not miss this reading for nothing. I would just like to say that this is an honor to meet you, Dr. Yoko Kato, not only for your performance in the operating room, but also for the mission of empowerment and support for women. You are a role model to follow, and it's an honor to be in the same meeting with you. Dr. Kato, you are an inspiration for us, for the medical students. Thank you. Dr. Bennett, you have an announcement?
Yes, thanks everybody for a great webcast. We're trying to change the structure. We're having short Zoom webcasts with the speakers and anyone in the audience that wants to come to this Zoom. Right now, the link is in the chat. Hopefully, Dr. Cato and a few of the doctors can come just to say hi to the students, because the students, I think, want to meet the neurosurgeons in a human way, to see their face and to meet them all the way from Japan. They're in South America. So welcome to everyone, especially Dr. Cato and Dr. Watanabe and Goto. So I hope to see everyone there.
Yeah.
The link is in the chat box. Just copy it, Dr. Cato, okay?
Thank you.
Just stay a few minutes and say hi to the students. They're dying to meet you.
Sure.
Okay,
thank you so much,
everybody.
Professor Cato.
Yeah.
Professor Juan
So-
Gómez Amador, Professor Chadad.
Thank you very much. The medical student is our future. So thank you so much.
Yeah, just take that link, get that link, Dr. Cato, to come into the next Zoom, okay? Really, just for 5 minutes, that's all. Okay, we'll see you there.
Okay.
Thank you all.